right, I think I'm going to get started. It's 9 o'clock. I'm going to be talking today about withdrawal syndromes. I hope my voice holds out for the whole lecture. I've got an influenza-like illness, so we'll see if it can hold out. But we just want to talk today about withdrawal syndromes. We'll start with going over some basic principles of withdrawal syndromes. We'll talk quite a bit about ethanol withdrawal because it's the most complex of the withdrawal syndromes. Sedative hypnotic withdrawal, opioid withdrawal, cocaine abstinence syndromes, SSRI withdrawal, and clonidine withdrawal. And let's start with some basic terms. The dependence, addiction, and withdrawal. Remember that there's a difference between dependence and addiction, right? And dependence can be both physical or psychological. Physical dependence are people develop withdrawal symptoms with cessation of use, whereas psychological is a kind of intense craving and preoccupation with access to that substance. Whereas addiction is when the use of a substance starts to have impacts on people's relationships or their job, and or problems with the law. So those are all situations that kind of push dependence into addiction. So you can have physical dependence without being addicted. And an example of that would be somebody with chronic pain who is chronically using a substance, or somebody on clonidine for their blood pressure. Those are patients who are physically dependent, but not necessarily addicted. And remember that withdrawal basically only occurs in people who have physical dependence, and it can occur either with cessation or a decrease in use. Tolerance is something that's very closely related to withdrawal. And basically, the idea of tolerance is that you require increasing doses of a substance to have the same clinical effect. And this is really directly related to physical dependence. There's also the concept of cross tolerance, where different substances that share a mechanism of action will share tolerance as well. So, examples of things that act on GABA, like ethanol, benzodiazepines, barbiturates, there's cross tolerance between them. So let's start with alcohol withdrawal, because it's the most complex of the withdrawal symptoms. Alcohol acts on two different receptors primarily. One is on the GABA receptor, and the GABA receptor is linked to a chloride channel. And when GABA binds to the GABA receptor, chloride comes into the cell and makes it more polarized and less likely to depolarize. And so that's basically inhibition. It also it acts as an agonist on the GABA receptor. It also acts as an antagonist on the NMDA receptor, which is a glutamate receptor that is linked to a calcium channel. And when calcium comes into the cell, it makes the cell more positive and closer to threshold and more likely to depolarize. So that's an excitatory postsynaptic potential. So in general, we have this balance between inhibition with GABA and excitation with glutamate. If you have too much inhibition, you have coma. If you have too much excitation, you have seizures. And if they're in perfect balance, that's what we call consciousness. And when people are chronically using alcohol, they're basically having an excess of GABA effect and not enough glutamate effect, and the body adapts to that. It downregulates GABA receptors, it upregulates glutamate receptors, and then in order to maintain balance, in the absence of alcohol, it's going to be shifted towards the glutamate side of the equation, and you need alcohol just to be normal. So the manifestations of alcohol withdrawal, there's four main manifestations, right? There's alcoholic tremulousness, which is what I think most people think of when they think of alcoholic withdrawal. That kind of adrenergic state, tremor, and we'll talk a bit more about that in a moment. There's alcohol withdrawal seizures, and we'll talk about the characteristics of alcohol withdrawal seizures. Alcoholic hallucinosis, and then finally delirium tremens. And these are all independent. Any of the three lesser syndromes can progress to delirium tremens, but you don't have to have alcoholic tremulousness to have alcohol withdrawal seizures or alcoholic hallucinosis. And that's a kind of common misconception. Somebody who's with alcohol use disorder comes in with a seizure, and people think, oh, maybe it can't really be from alcohol withdrawal because they're not tremulous, or they don't have the other signs that I typically associate with alcohol withdrawal. So alcoholic tremulousness are these adrenergic signs and symptoms. People get headache, palpitations, GI upset, diaphoresis, trouble sleeping, anxiety. And typically, this comes on pretty soon within cessation of drinking and resolves within a day or two in people in whom it resolves. Sometimes it can progress to DTs. Alcoholic hallucinosis, I love the original name for this. Historically, it was called Kraepelin's hallucinatory insanity. And this typically happens 12 to 24 hours after the last drink. And the hallucinations are, people tend to think of this pink elephants thing. And I know the Delirium Tremens beer has the pink elephant as their logo. But it's actually not typically visual. They're hallucinations that we typically would more associate with psychiatric illness. They tend to be auditory and persecutory type of hallucinations. There's no global clouding of the sensorium, so the person can be awake and oriented and still having these hallucinations. And this typically, again, resolves within a day or two unless it progresses to DTs. Withdrawal seizures typically happen much earlier than most people expect, typically within 24 hours of the last drink, and most of them happen within 8 hours of the last drink, so pretty soon after a cessation of drinking. About 3% of chronic alcohol users will experience some type of withdrawal-associated seizure, and it's about 50% of alcohol withdrawal will ultimately have some type of seizure. It's usually a single brief episode. It's not common to have status epilepticus. Sometimes it'll be 2 or 3 episodes of seizure, and it's typically a generalized tonic-clonic seizure. So delirium tremens typically happens a little bit later than the other syndromes, typically about 2 days or more after the last drink. And the real cardinal features of delirium tremens are disorientation and confusion, that delirium part, and then the autonomic instability. So they have all the adrenergic signs of alcoholic tremulousness, but then they start to have abnormal vital signs and they start to be confused. So when delirium tremens was first described in 1914 by Osler, the mortality was quite high, 14%, right? If you think about all the people that we see, that's a pretty high mortality. By the 1950s, it had dropped to 5%, and a lot of that was just from improvements in supportive care and also recognition by work by Victor and Adams at Mass General that this that it's often precipitated by some other disease state. So infection, some other illness, metabolic deficiencies. And so, being sure to recognize those other things that actually precipitated with the withdrawal and treating those things significantly drop the mortality. So again, remember that when we see these different manifestations, these are independent, but that any of them can progress to delirium tremens. So when we're treating a patient with alcohol withdrawal syndromes, typically we're going to use rapidly escalating doses of benzodiazepine. That is really the best, most effective way of treating. And when it's available, I think that diazepam is really the ideal agent when given IV because it has a rapid onset of peak effect. Within 5 minutes, you're as sedated as you're going to get after a dose of intravenous diazepam. But it also has a long half-life and it has active metabolites. So once the patient's symptoms are under control, to some extent, the diazepam kind of tapers itself off because of the active metabolites. So typically, you can dose every 5 minutes if you rapidly assess after the dose of your diazepam. If you're not going to use diazepam, midazolam is probably the correct benzo to use. Lorazepam is suboptimal because the sedative effect of lorazepam, although it's much more rapid as an anticonvulsant, as a sedative, lorazepam typically takes 15 to 20 minutes to reach peak effect. So either you're going to take a long time between doses while you're escalating your dose, or you start to stack doses, meaning giving an additional dose before the previous dose has peaked, and then you run into real risks of oversedation and need for intubation. So diazepam or midazolam are probably better choices when you're deciding to escalate your doses of benzodiazepine. When you get to 200 milligrams, which was pretty common when I was a tox fellow at Bellevue, uh, pretty uncommon in our clinical setting. Our patient population doesn't have as severe alcohol withdrawal, but we typically are going to add on something else. And phenobarbital is a good choice. It also acts on the GABA receptor, but in a different site on the GABA receptor. And 130 milligrams IV is a reasonable thing to start with, and you can give that every half hour up to 3 times. Magnesium isn't well studied in this setting, but these patients tend to be magnesium deficient anyway, and magnesium is an NMDA antagonist, so probably reasonable to at least give a dose of magnesium. And then if patients are really resistant, then we want to consider something like propofol, which is the only agent that we typically use that acts at both GABA and NMDA sites, treating both sides of alcohol withdrawal. We don't want to forget giving thiamine in these patients and looking for precipitating factors. So how do we assess whether a patient needs more benzodiazepine? CWA-AR is probably the best validated score for this. It's a series of questions. I don't think anybody has this memorized. I certainly don't. So you typically are going to either pull it up on your phone or print it out and take it to the bedside. And some of them are observations that you make at the bedside and some things that you ask the patient. And it's a score that goes from 0 to 67. And if the patient has a score over 8, they probably need more benzos. And if they have a score over 15, that's a sign of severe withdrawal. This is the algorithm that they use at Bellevue, and they chose to use RAS instead of the CIWA score, which has the advantage of being much simpler, but also is not really as well established in evidence as the CIWA score for this purpose. But they basically will rapidly escalate their dose in patients with severe withdrawal, increasing every 5 minutes. When they get to 200 milligrams, they think about adding on phenobarbital for resistant alcohol withdrawal. Remember that when we're using any benzodiazepine or barbiturate, we're really only treating the GABA side of the NMDA and GABA balance, and that when we use propofol, that we're acting on both, and magnesium to a lesser extent, we're acting on the glutamate side. Don't forget that we need to look for these precipitating factors, and those can include any type of infection. Pneumonias are common in these patients, meningitis, pancreatitis, Wernicke's, electrolyte disturbances. Remember that these patients typically are hypokalemic and hypomagnesiemic. It's common to see alcoholic ketoacidosis in patients with alcohol withdrawal. Sometimes they have surgical pathology, right? They stop drinking because they developed an API, or there may be occult trauma, and just doing a good head-to-toe exam on these patients is important. So there are a lot of other things that have been advocated. Most commonly, like in the surgical literature, people have talked about giving Haldol. Haldol is really not optimal. It's not treating the underlying problem. It lowers the seizure threshold in patients who already are at risk for seizures. It prolongs QT in patients who already might be hypokalemic and hypomagnesiemic and are at risk for torsade. So really, don't recommend using Haldol in these patients. Dexmedetomidine is popular in the critical care community sometimes for treating alcohol withdrawal, and it does sedate the patient and it makes the vital signs look better, but it's not treating the underlying problem. You're not really acting on GABA or NMDA. You're kind of, in a sense, masking what's going on in the brain. Ketamine, in theory, makes sense in that it is an NMDA antagonist and could potentially be an adjunct, but it's just not that well studied yet for this purpose. All right, so let's look at other sedative hypnotic withdrawal. And in general, it's the same principle as alcohol withdrawal. Remember that withdrawal from a sedative looks like intoxication with a sympathomimetic. And in general, sedative hypnotic is less complex than alcohol because it in generally only involves GABA. It doesn't involve glutamate antagonism. And all GABA drugs have cross tolerance with benzos. There are some more complex sedatives So clonazepam is a benzodiazepine, but it's also serotonergic. So when you give other benzos, you're not completely replacing what they're missing. So it's reasonable to give a dose of clonazepam to patients in clonazepam withdrawal, in addition to escalating your other benzodiazepine. And then GHB is cross-tolerant with benzodiazepines, but in addition to acting on GABA, there are specific GHB receptors that GHB acts on, and you're not completely replacing what's missing. So sometimes these patients need very high doses of benzos to get their symptoms under control. We don't have a standardized scoring system, so it's more clinical judgment. CIWA really isn't validated for this. So if you wanted to use RAS or whatever other scoring system as a measure of how sedated they are, you could use that. Opioid withdrawal is one that is really important that we see a lot of and probably see a lot more of, or we'll see a lot more of if you go to another setting besides our hospital, which has probably a lot less than other parts of New York City and other parts of the country. And opioid withdrawal, this cartoon kind of shows a lot of the features of it. Vomiting, diarrhea, increased motility in the GI tract, sweating, large pupils, tachycardia. Piloerection is really classic, and it's a good one to look for because it's involuntary. People will get muscle cramps, and this all occurs with cessation of opioid use. Seizures are not typically a feature of opioid withdrawal, with two exceptions. Neonatal opioid withdrawal can involve seizures, and that's the exception to when it's life-threatening as well. And tramadol withdrawal can involve seizures. In general, opioid withdrawal isn't life-threatening unless it's neonatal opioid withdrawal and also precipitated withdrawal. So somebody who gets a large dose of naloxone and abruptly reverses their opioid potentially can have life-threatening withdrawal, particularly if they have other comorbidities that put them at risk from an adrenergic state. Another thing that can occur with naloxone precipitated withdrawal is opioid-induced pulmonary edema. And this typically occurs when people get large doses of naloxone, putting the patient into withdrawal without ventilating the patient first. Because when you are taking an opioid, it makes you hypoventilate by making your brain tolerate high levels of CO2. And if you abruptly reverse that without ventilating the patient first to bring down the CO2, then the brain wakes up and it responds to that high CO2 by releasing catecholamines that make the vascular bed in the lungs more permeable. Patients also tend to do something called the Muller maneuver as they wake up, which is inspiration against a closed glottis, and create hydrostatic forces that also pull fluid into the lungs. So most commonly precipitated by naloxone, but it can occur just from the opioids themselves and was actually first described by Osler before naloxone was developed. So when we want to treat opioid withdrawal, the best thing is to give them what they're missing, which is opioid agonism. And so traditionally, when I was in training, methadone was the treatment of choice and is still a reasonable treatment. You can give 10 milligrams intramuscularly or 20 PO. The PO is probably less desirable because a lot of times patients will vomit and then you're not sure exactly how much of the dose that they got. Um, Buprenorphine initiation is in patients who are willing to initiate buprenorphine is another strategy and probably our primary strategy these days for treating opioid withdrawal syndrome. And we do have protocols for buprenorphine initiation that are on the website for the department. And I believe that there's going to be a talk on the next month, an update on our treatment for opioid withdrawal. So we have OBS pathways for this, and we have the catch team that's really helpful in talking to the patient and deciding on what's going to be the best approach for an individual patient. Things that you might see in other places and that were common, I think, at our hospital before the culture changed and people were more willing to use substitution therapy are treatment for symptoms. So clonidine, benzodiazepines, antiemetics. This is not giving the patient back what they're missing. So it's kind of the same problem. Um, as using dexmedetomidine for for treating alcohol withdrawal. Sorry, I was just seeing that there's a question in the chat. Let me just look at that. Are there other mechanisms of mortality for precipitated withdrawal other than ventilation, pulmonedema, and hypercapnia? I think the other mechanism of mortality with precipitated withdrawal is an adrenergic state, and typically in an older patient with opioid dependence, with underlying cardiovascular disease, right? They can get an MI from going into withdrawal. Is probably the biggest feature that you'll see. Um, so again, treating symptomatically, if you don't have access for some reason in a certain clinical setting to methadone or buprenorphine, then you can treat symptoms. It's better than doing nothing, but it's definitely not the treatment of choice. So clonidine, we'll talk about how that works. Benzodiazepines just to kind of sedate the patient a little bit, antiemetics to treat the nausea, but again, you're not treating the underlying problem when you take this approach. Clonidine does have some actual effect on the opioid withdrawal itself, not by acting on opioid receptors, but by acting on the same second messenger system in the same parts of the brain, in the locus coeruleus. It both increases, the alpha and mu receptors both increase calcium influx or efflux from the cell. And so that is going to potentially mitigate some of the signs and symptoms of opioid withdrawal. Okay, so next we can talk about cocaine abstinence syndromes. I wouldn't really call it withdrawal exactly, although it could be seen as a form of withdrawal. The first I'll talk about is cocaine washout syndrome. And this is something that occurs in patients who have depleted dopamine after a binge. And typically, if they're chronic cocaine users, they'll have downregulated dopamine receptors. And these can be really challenging patients because they don't need any specific treatment other than to sleep and not use cocaine. There's no like substitution therapy for this. It's completely supportive. And the problem is that it can be very hard to motivate these patients to go home and sleep. It's hard to even get them to talk to you sometimes. You'll be trying to have a conversation with them, and they'll be kind of nodding off in the middle of talking to you. So this is where it can be really helpful if the patient agrees to get their family involved to try to help them get home and to help them get through this setting. And also getting the catch team involved in any of these withdrawal syndromes is going to be important as well. Another cocaine abstinence syndrome that's a lot more rare is something that's been deemed called crack dancing, which is a description of this chorioathetoid movement that occurs from dopamine depletion in the basal ganglia. This is a gif of Sam Jackson's character Gator from the movie Jungle Fever, who's kind of trying to demonstrate that. And all of these things come from dopamine depletion. So this is an animal model, monkey model of cocaine dependence, and this is PET scans of the monkey brain, specifically highlighting dopamine D2 receptors. And on the left, you can see the cocaine naive monkey with the basal ganglia lighting up from the normal dopamine activity. And on the right, we have the cocaine experienced monkey, which would be a great band name, after 227 days of abstinence, right? So like almost a year after the last time this monkey was exposed to cocaine, you can still see that the basal ganglia has significantly decreased dopamine activity compared to the cocaine naive monkey. So really persistent effects of chronic use of cocaine. Let's take a little bit about SSRI withdrawal, which is a really not as well characterized syndrome. There's a lot of different symptoms that have been attributed to it. You can see all of these things that are listed in this public health poster. Some of them, there's some redundancies. I don't know the difference between an electric zap-like sensation and an electric shock-like sensation. But there's, a lot of different features that are kind of things that we associate with a lot of different types of withdrawal syndromes. I think one thing to be aware of, I know Bob Hoffman at Poison Control likes to talk about serotonin is the happy neurotransmitter. And if you abruptly take away something that raises your serotonin levels, it's not surprising that patients are going to be miserable. So typically the treatment for this is basically to restart their SSRI. Right. This typically happens when somebody is on an SSRI, particularly a shorter acting one, because pretty rapidly goes away. Things like Prozac, maybe it happens less because it's so long acting and the serum concentration falls more gradually. But you basically want to restart their SSRI, and they'll need to gradually taper down, not just abruptly stop the SSRI. So some of these patients might need benzodiazepines or antiemetics as symptomatic treatment, but really, again, as the kind of basic principle for all withdrawal syndromes, except for cocaine, is to give them back what they're missing, give them back the drug that they were taking. So I have a couple minutes for clonidine withdrawal. Anyone know the movie this is from? David Cronenberg movie, Scanners. If you have seen it, you'll know the next image. So the clonidine withdrawal is people who are chronically on clonidine, and remember that clonidine basically acts on central alpha receptors in the brain to decrease sympathetic outflow, and that lowers your blood pressure. But if you chronically take it and abruptly stop taking it, you're going to have increased sympathetic outflow, and you'll get acute, severe hypertension, headache, flushing, sweatiness, hallucinations, and anxiety. And really, what they need is to give them back what they're missing, the clonidine. Clonidine is really a suboptimal drug for treating blood pressure because it's so short acting and has such a significant rebound effect when it's stopped. And so, once people are on it, they need to be gradually tapered down. But we'll see patients sometimes if they've been waiting in the ER for a long time to be seen and they're on clonidine, their blood pressure may be through the roof because they're due for their next dose because it's a TID drug, and they'll have this really high blood pressure. And so those are, I typically don't use clonidine to treat hypertension, but in patients who are on clonidine and have missed their dose, then clonidine is what they need. And absolutely, those patients should all get clonidine to treat all of the effects of this withdrawal syndrome. So just to sum up, withdrawal occurs when we can discontinue or decrease the dose of a substance in patients who have physical dependence on that substance. And alcohol withdrawal involves decreased GABA and increased NMDA activity. There's 4 independent manifestations of alcohol withdrawal, and seizures and hallucinosis can occur without tremulousness, but any of them can progress to DTs. Treatment of alcohol withdrawal is benzodiazepines, barbiturates, sometimes propofol. Think about magnesium as an adjunct. Always look for precipitating illness in patients with withdrawal. People don't usually just stop using for no reason. There may be some psychosocial reason, or it may be a physical reason because they're ill from something else. Sedative hypnotic withdrawal is managed similarly to ethanol withdrawal. Typically, they don't need propofol. Typically, benzos are really all you're going to need. Opioid withdrawal is rarely life-threatening unless it's precipitated or neonatal opioid withdrawal, and we're going to treat it with methadone or buprenorphine induction, or if you have no other choice, you can treat with symptomatic treatment. Cocaine abstinence syndromes are treated supportively, and again, remember that it can be helpful to get the family involved. Otherwise, it can be challenging to actually get a patient out of the ER. SSRI withdrawal is treated with reinitiation of the SSRI, then tapering, and you can do symptomatic treatment in patients who have severe anxiety or nausea and vomiting. Clonidine withdrawal manifests as increased sympathetic outflow, severe hypertension, and you treat it with clonidine. And we have a couple minutes for questions. And I'm also going to put up this QR code. Noah and I are working with New York City Poison Control to do a study on toxicology education, and we'd appreciate if people could fill out this survey as a baseline. And let's see.
Thanks, Coach. I had some questions. I guess my first one is the survey only for residents, or do you want faculty to do it too?
I believe this is just for residents.
Okay, cool. I have 2 questions about the lecture. First one surrounding both are alcohol withdrawal, surrounding disposition. What are kind of your thoughts about admission, ICU floor, and discharge, seizure secondary to withdrawals on an automatic admission, and when are you considering ICU involvement?
That's a good question. So I think that it really depends on your clinical setting. I think that I probably have a higher threshold for sending somebody home than people would have in other settings. I know I've talked to uh, Matt Racinti, former downstate resident who works out on the West Coast, and it's not uncommon there for them to just give phenobarb in the ER and discharge a patient, which I think by the time someone, in my mind, is requiring phenobarb, they definitely should be admitted, but they'll use phenobarb without giving a benzo first. So there's different styles. I think the evidence base for phenobarb is still kind of in progress, so it's a lot less strong than for benzodiazepines, which have such just a long history of use and just very safe use. It's really safe to escalate them. You have a lot less over sedation than when you start to use phenobarb. But and it looks like Camilla has a question that is related to that. But I'll get to
That was
that.
my second question, so
Yeah.
it's good to get into it.
Yeah. So
Yeah.
I think that there's some evidence that you could give a dose of phenobarb up front in patients with severe withdrawal. I don't think that's wrong. It's just a different style. I personally, I really think that diazepam is such a great drug for treating this that I like to start with that first, especially in our population that usually doesn't have the most severe withdrawal. Usually, a few doses of diazepam is enough to get their symptoms under control. You can use chlordiazepam epoxide, Librium, in patients who are taking PO and have mild withdrawal, or you could give a dose prophylactically in patients who you anticipate that they're going to have significant withdrawal. I guess one thing that I didn't mention, and that I think is going to factor in into whether both admission and ICU admission is whether the patient has ethanol in their system while they're presenting withdrawal, because the patient who's in withdrawal with a serum ethanol concentration of 300 is very different than the patient who's withdrawing and has no alcohol in their system, because the patient with still having alcohol in their blood is going to be getting worse as they metabolize away that alcohol before they get better. So I think, if somebody needs a dose or maybe two doses of PO Librium while they're in the ER, I think it's reasonable to send them home. If they're needing multiple doses of intravenous benzodiazepines or they're getting phenobarbital, in my mind, that's somebody that should be admitted. And I also think that it's really, if you look well enough, you're going to find another reason that they need to be admitted. In a lot of these patients, they're going to have electrolyte disorders, they'll have AKA, they'll have some type of infection. Or at least observation, although I don't think that we have a protocol yet for alcohol withdrawal. I know that Dr. Berland is working on one. Um, so yeah, in terms of ICU, certainly anyone with resistant alcohol withdrawal. So in the Bellevue protocol, people who are getting 200 milligrams of diazepam, I do think that our hospitalists will probably be uncomfortable with doses a lot lower than that. But I think that that's usually was our threshold where I trained at Bellevue for my fellowship. I think at Jacobi, where I was a resident, alcohol withdrawal is a lot more like what we see here, where a dose of or two of benzos, and most patients their symptoms are under control, and those patients can easily go to the floor. Um, Ideally, if you're going to be frequently reassessing your CWIS score, that's something that it can be done by nursing, but it can't be done frequently enough by nursing on the floor for patients with severe withdrawal.
Yeah, so I guess it ends up being like a total cumulative dose, and clearly culture plays a big part of it and kind of resources.
Yeah, I think just because our institution, people are not seeing a lot of severe resistant withdrawal, that they're not comfortable with people with moderate withdrawal. So when people need more than a few doses of a benzo, a lot of the hospitalists may not be comfortable with that patient. And I think that the ICU might be a lot more willing to take them than they would at a place like Bellevue, where they're seeing it very frequently.
Yeah. And the seizure play factor at all in I mean, and I'm talking personally. I know
Yeah,
there's
I don't think a seizure by itself. I think people with DTs, often will belong in the ICU. But just a seizure by itself, alcohol withdrawal seizures usually don't go on to status epilepticus. So it really depends on how much benzo they're requiring. That is going to be my major guide.
And how about admission in general? Would you admit all seizure out withdrawal or
I usually do, just because it's a lot less predictable because the SIWA doesn't really reflect as well the extent of their withdrawal because they can have alcohol withdrawal seizures without having alcoholic tremulousness. So I'm a bit more concerned about those patients because it can be tougher to predict what's going to happen with them.
yeah? I'm pretty sure it is one of the Milliman criteria as well, so it makes it easier that way too.
So
Thank
let's.
you.
Oh, there's a lot of questions here. Okay. Prescribing a lithium taper from the ED on discharging a patient. That has never been my practice, but it is something that people do. And I think it's best to do it within the setting of having a protocol for it. Um, I think the problem with the Librium taper is that this has been studied, and symptom triggered therapy is far superior to a fixed dose taper. So, at least in the inpatient setting, even if just using oral doses of Librium and assessing people every hour and seeing whether they need a dose by CIWA score, they wind up having lower total doses of benzodiazepines and shorter stays, basically shorter course of needing a benzo. Whereas you kind of lose the ability to do that if you're just putting someone on a fixed dose taper. There's more oversedation with a fixed dose taper, and you're using more drug. So it's not something that I like to do. But it is something that is done, and it's certainly it's a reasonable practice. I just don't think it's ideal.
Sage, you may have addressed this. Just one quick question. Can you just discuss how many of our patients who are diagnosed with seizure disorder but have concomitant alcohol misuse or abuse disorder, and then they're placed on these anti-epileptics that may
Yeah,
or
and
may
that's a
not be
very challenging.
working, and they're actually in alcohol withdrawal? Can you just discuss that, please?
Yeah, I mean it's a challenging situation, right? Because somebody carries this diagnosis of a seizure disorder, and often we don't know what workup they actually had. Did they really have a seizure disorder, or did somebody misdiagnose their alcohol withdrawal seizures as a seizure disorder and put them on an anticonvulsant? Typically, when I was a resident, it was phenytoin. Now it's typically Keppra. Um, but there is the confounder that a lot of our patients with alcohol use disorder and alcohol dependence are frequently victims of trauma, and often head trauma, and so they have a reason potentially to have a seizure disorder. So some of them may actually have seizure disorders, and it's really difficult to sort out which ones they are. I think when I see a patient with alcohol dependence and I see them having a seizure, if they're supposed to be on a benzo, or I'm sorry, if they're supposed to be on an anticonvulsant and they haven't been taking it, I'll typically give them whatever I would give another patient on that anticonvulsant, that dose. But I would also definitely give them a benzodiazepine and treat it as if it was alcohol withdrawal in addition. So I think I kind of like a belt and suspenders approach, treat for both, unless I have a real reason to think for sure that they don't have a seizure disorder. It can be really tough because a lot of these patients' charts, there's just hundreds of visits, and there's no way to really sort out what workup they had sometimes.
Dr. Wiener, someone with when you take two different patients, one with like, let's say they haven't been drinking alcohol for that long, and someone that's been drinking a lot of alcohol for a really, really long time, is there like a difference in timing where they're out of the quote unquote window? So like someone that's been drinking for a really long time, maybe really, really downregulated their GABA receptors, how long does that take to recover and come back to like a normal C type of state?
I don't know that I've seen data on that. I mean, I think that the longer you've been drinking, the harder it is for somebody to stop, and the longer that they're going to be at risk for withdrawal. But there are real changes, and there's also genetic factors as well. There's certain populations that seem to have more severe withdrawal, and it's not clear why. We do know for sure that as people are chronically drinking, the GABA receptor can be made up of a number of different subunits, and the type of subunits that make up those GABA receptors actually change over time. So there's really, at the cellular level, there's really changes, structural changes in their receptors that occur as people have been drinking for a long time. In addition to genetic factors that contribute to the population of receptors that people have. So it's really complex and not studied enough to really have an easy answer to that.
Thank you.
And Dr. Silverberg saying, does an alcohol withdrawal seizure patient have an abnormal EEG even temporarily? I think when they're having a seizure, they do have an abnormal EEG. But I think in general, toxic seizures are a little bit different from epilepsy on an EEG. Because when you have epilepsy, you have an epileptogenic focus in your brain. And it's spread from that focus that leads to a generalized seizure. Whereas when you're having a tox-mediated seizure, whether it's from a withdrawal state or from a toxin that causes a seizure, every neuron in the brain is trying to seize at the same time. And that's why traditional anticonvulsants don't really work well for tox-mediated seizures. And maybe this is what Dr. Smith was trying to get at, and I missed it when she brought up the question. But if it is really a tox-mediated seizure or a withdrawal-mediated seizure, traditional anticonvulsants don't work very well because they're more focused on trying to block spread of an impulse from one area of the brain to the rest, rather than globally depressing the neurons by GABA activity. So, I think maybe you could tell the difference on an EEG, but they would definitely still have an abnormal EEG during a seizure.